Welcome to this Bone Matters session. Our spotlight today is on osteoporosis and how it affects men. So you may be watching this as a man who's got osteoporosis and maybe fractures, that's broken bones, or you may just be thinking that you're at risk. Perhaps you have a friend or a family member with osteoporosis and you're wanting to find out more. So our aim in this conversation is to hopefully increase your understanding of the whole topic. Now, we often say women are more at risk. We know they are. They have smaller frames, they lose estrogen at the menopause, they live longer, and bones do get weaker as we age. But we also know that men too lose bone strength and break bones easily in just the same way. So I'm delighted today to welcome Dr. Stephen Tuck, who is an expert in the field. And we're going to be discussing this whole subject and look really at what are the issues for men, how are they different, but also very often how they are the same. So as I say, welcome, Dr. Tuck. Perhaps we could just start by you giving us a bit of an introduction. Tell us who you are and what you do and where you work. Thank you.
Well, thank you very much for asking me. I'm a consultant rheumatologist by trade. I work at James Cook Hospital in Middlesbrough, and I have had an interest in osteoporosis for 20, 30 years, something like that. I started off in the field of osteoporosis way back when I was a registrar, and I got involved in male osteoporosis at the time because, well, fundamentally I wanted to do some research, and they'd just done a study of women's views of forearm fractures, and I thought, well, why can't I do that in men? So I did, and it never occurred to me at the time that people wouldn't think of forearm fractures in men as not being osteoporotic. But they weren't. This is way back in the 1990s. People thought that forearm fractures in men weren't osteoporotic fractures because they didn't go up over time, like they did in women, and so they kind of got forgotten about. And so I did this study in forearm fractures in men and showed that these chaps actually were osteoporotic. About 40% of them had osteoporosis on bone density scanning. So that's how I got involved, and I've been involved with the field ever since.
Thank you. It's good to understand, really, because as I say, we do still think of it wrongly as just a women's condition. Perhaps you could just take us back a little bit of a brief history lesson maybe, and explain why is it that we think of or sometimes wrongly think of it as a women's condition.
Yeah, it's partly historical and partly because it's much more common in women. So if you look at the data, roughly speaking, 1 in 2 women over the age of 50 will sustain a low trauma fracture in their lifetime. The numbers for men are about 1 in 5, which is still a lot, but that means you don't see so many of them, and so people didn't think about it. Which, if you look back at that now, you think, well, that's obviously not the case. But it tended to be ignored to some extent. But over time, awareness has increased, partly through people like me, but partly through the work of the ROS. The Royal Osteoporosis has done very good work promoting this over time, and it's generally become much more aware around the world, and people have done a lot more research on it.
I guess, first of all, it was a focus, wasn't it, on this sort of whole diagnosis was in postmenopausal women because they were losing estrogen, and that was the sort of direct connection with losing bone.
Yeah, that's correct.
So great that we're focusing on this today, and as you say, things have improved. I mean, do you think there is still repercussions for men? I mean, do you think there's misunderstanding and that men sometimes don't get diagnosed still, or it's not recognised as osteoporosis?
Yes, I would agree with that. It depends a bit on where you are as well as to the likelihood of you being picked up. So certainly before we had a fracture lasing service in Middlesbrough, say, when we did audited the rate at which people were treated, and if you looked at women who had a hip fracture, only about 20-25% of them were actually getting treated. This before we had a fracture lasing service. And in men, that number was about 3%. the figures drop dramatically if you had any other fracture type. And if you're a chap who'd had a forearm fracture or spine fracture, you may as well pack your bags to go home because nobody investigated you or treated you. Now, bearing in mind that at the time we did that audit, we'd had an osteoporosis that was running for about 20 years in James Cook. So it just shows you, with the advent of fracture laying service, I think that's changing. Most FLSs are designed to pick up anyone, be that man or woman, who's had a low trauma fracture over the age of 50 and do something about it. So I think in places where you've got an FLS, it's probably less of a problem than it was. But where you don't have one, I would imagine the figures would be very similar. It's a very poor pickup.
So what you're saying really is the important thing being, if you're not picked up and you're not investigated, then you're not going to get the drug treatments that are now available to strengthen bones. So yeah, the importance of these services, and presumably the impact is very much. We're going to talk a bit about differences, but in terms of the impact of having fractures, broken bones, it's going to be very similar for men and women in terms of some having long-term pain problems with spinal fractures, or the huge impact of hip fracture on mobility and future life quality. Is there anything particular in that that's useful?
Well, men tend to do worse than women when they've had a fracture. They tend to fracture a bit later in life. They tend to have more problems, more other medical problems when they do fracture. But even if you adjust for the age and multiple medical problems, they still have worse outcomes. And those outcomes are in terms of their disability and problems afterwards. So after a hip fracture, about 55% get discharged in nursing homes. Only 21% are living independently. They do very poorly in health questionnaires. So if you look at vertebral fractures in men, for example, they do very, very poorly on general health questionnaires. So they suffer a lot with pain, they suffer with loss of function, and they suffer with reduced mental well-being. Even forearm fractures, 30% have long-term complications.
So really important that we're focusing on this, and I think we still don't talk enough about the impact on men. So thank you for explaining that. Let's move on a little bit. I wanted to talk about diagnosis, which is around, sometimes we hear from younger men who've been picked up with a very low bone density and want to know, have they got osteoporosis? And I think this is where it's important, I would say, to have a proper assessment, hopefully from a specialist who can help you understand what that means. But am I right that some people may just have a very small frame? They may be their peak bone mass, the best they ever got, is going to be a bit lower just because they're of a smaller frame, and it doesn't always mean weaker bones. Is that a fair point? Just for the younger listener.
Yeah. So if somebody is of short stature, then it will read a lower bone density just because they're shorter in stature. So you can easily get caught out by that. So you do have to look at the height on the DEXA scan.
And this is where I think seeing a specialist who knows the subject in great detail is really important. And I think one of the things we were wanting to discuss was, should men be referred to a specialist? And I think ideally they would be. Would you agree with that? It may not be easy, but
I would agree with that because osteoporosis is less common in men. When it occurs, it's a bit more likely that they've got underlying reasons for that. That's especially true if you've got a younger man. And those secondary causes need looking for, sometimes quite hard to find them. And if you can find the underlying cause, then you can treat that and get a better improvement. And sometimes you need a specialist to work that out. Also, the treatment of men can be a little bit more complicated than in women, because you have to work your way around which medications are licensed for men and which ones aren't, and also which ones are licensed in the set of circumstances that you've got for men, which might be different to what it is in women.
So ask to see, hopefully, to get that right referral, and I think that's an important message for our audience. So you've talked a bit there about finding out about underlying what we call secondary causes. Could you talk a bit more about that? I mean, I understand that about half of men with osteoporosis, there is something going on that could be the underlying cause. Is that the case?
Yes, it is. As I've alluded to briefly, men are more likely to have an underlying reason for their osteoporosis than women. And if you look at the surveys, the numbers work out about 50% of men will have a secondary cause. It can be higher. It depends what you include in secondary cause. I mean, do you include smoking in there or not? So it depends what you include in the secondary causes, but at least 50% of men will have an underlying reason. This is much higher than women, where it's about 30%. They're worth looking for. Those secondary causes overlap quite a bit with the women. So, steroids, celiac disease, you can get those in both genders, obviously. So that they do overlap. But some things are much more specific to men. Like prostate cancer is quite good at causing osteoporosis of itself, and the treatment of prostate cancer causes bone loss. Because they suppress testosterone to treat the prostate cancer. So that causes bone loss and increased fracture rates over and above what you can estimate with a fracture risk assessment tool. So that's something a bit more unique to men. HIV is somewhat more common in men than women. So again, that's another thing that we sometimes find. And the whole list of other secondary causes, as long as your arm really gets longer. But a lot of those overlap with women.
And presumably some other sort of rarer conditions that affect hormone levels, affect testosterone.
Yeah. So not having enough testosterone is another thing you can find quite frequently in men with osteoporosis, especially younger ones, are worth looking for. Because you find somebody hasn't got enough testosterone, you replace their testosterone, you get a nice big increase in bone mineral density. And there's nice data to show that doing that will work really well in younger men. It doesn't work so well in older men for all sorts of reasons. Replacing testosterone in men over the age of 60 tends to increase heart attack rates and prostate problems. Younger men, especially under 50, testosterone replacement will work well if they haven't got enough.
Okay, well, that takes us on to drug treatments that people might be able to take, or men might be able to take, to strengthen their bones. And I know that many of the treatments are much the same, but there are some specifics here. So I just wondered if you could talk a bit about the difference between drug treatments for men and women, which ones perhaps they can't have, and which ones they might not have access to. Perhaps we could start with the ones that are really not suitable, the sort of treatments that women...
Hormone replacement therapy in women has been used a great deal over time, but giving men estrogen doesn't work very well. They tend to have things go wrong that they don't like very much if you give estrogen to them, so that doesn't work. Raloxifene is another one which you use in women occasionally, but again in men the side effects for men tend not to make it very well tolerated. So we don't tend to use raloxifene in men either. On the other hand, we've got a full range of bisphosphonates to use. They have all been used in men. They've all got good evidence that they work well in improving bone mineral density. Everything from alendronate to zoledronate now has good evidence in men. And they're licensed to treat men, which they didn't used to be. It's actually relatively recently they've all been allowed to be used in men. The other problem we have when treating men is that quite a lot of drugs have bone density data, but they don't have anti-fracture data, because the studies that were done weren't big enough to detect a change in fractures. So that's another problem that we tend to have. Having said that, the International Osteoporosis Foundation does say that if you've got bone density equivalent data to women, then they should be fine to be licensed. Teriparatide, parathyroid hormone therapy, that is also licensed in men. We can use it for men. Denosumab has pretty good data in men. In fact, some of the biggest studies were done with denosumab in men, so that's got good data. Unfortunately, romosozumab, which is the latest big thing, most impressive anabolic agent that we have for treating osteoporosis, builds bone up like nothing else, and works very quickly, isn't licensed in men. It doesn't have anti-fracture data, but again, it does have a reasonably sized amount of information on bone density. So there was a decent study which showed an increase in bone density that was very similar to the increase you get in women. And the amount of men involved in that and that kind of data is actually very similar to much of the data we have, say, with the bisphosphonates that we now use to treat men. So hopefully we'll be able to use it eventually, but at the moment we're not.
So what you're really saying is a lot of these drugs should and could very well work in men and be
Yeah,
appropriate,
absolutely.
but because we haven't got lots of research that specifically looked at men and really showed that it stops them breaking bones or reduces the risk of them breaking bones, because we don't have that, they haven't been approved. Is that what you're saying, really?
Yeah, yeah. I mean,
The
most
process,
of them, yeah, a lot of drugs have been approved, but some of the ones that haven't is because they haven't got anti-fracture data yet.
Okay.
Which hopefully will change.
Okay, yeah, so something to look forward to for the future, hopefully.
Hopefully.
And anything else on the horizon, either in terms of drug treatments or any other new research that's going on with men that our listeners will be interested in?
Okay, yeah, well, there's a medication called abaloparatide that is kind of related to parathyroid hormone. It's actually not quite the same molecule, but that has recently had some studies done in men.
Just a quick mention of lifestyle. We don't have a lot of time, but people are interested in what they can do for their bones. Much the same for men and women, I'm assuming, in terms of how to help yourself if you can.
Yeah, absolutely. Weight-bearing activity, very important. That will certainly help, just as you would with women. Make sure you don't smoke, don't drink too much, eat all the right things, plenty of calcium, vitamin D in your diet, and the very same things that you would recommend in women, really.
So lots of positives there. And I think what we're saying is, yes, men are affected by, but can be helped in the same way as women. So hopefully there's been some information from here that you'll be able to take away and act on. Anything else you'd like to add at all? Is there any other research coming up, Dr. Tuck, that you know?
Well, I think what I would say is really anyone who is seeing a chap who has broken a bone through low trauma or has risk factors for osteoporosis, please think about it. Please do think about it, and please do treat them.
So a message there, I think, for any healthcare professionals listening, and also, I guess, a message for you if you're a man listening or you know someone in that situation. So don't hesitate if you think you're at risk or you're breaking bones easily, to go and have that conversation with your doctor. So thank you. That's been really useful. Thank you, Dr. Tuck, for all that information. I know our audience are going to find it really helpful. And thank you all for listening. I hope it's been interesting as well as supportive. We'd love to hear your feedback. There's some links below so that we can improve further sessions. And thank you and goodbye.
Hello everybody, I'm Kirsty. I'm one of the specialist nurses here at the Royal Osteoporosis Society, and I'm delighted to be joined in conversation today by Nick Vine, who is living with osteoporosis and fractures. And Nick is going to talk to us today about what it's like to live with the condition when you are one of the 1 in 5 men that has osteoporosis here in the UK. So a big welcome, Nick.
Thanks very much, Kirsty.
So to start, perhaps you could tell us a bit about what did it feel like when you were first diagnosed with the condition? Did you have any difficulty accessing information and support for your diagnosis?
Yes, I mean, it wasn't straightforward for me. I actually knew I had osteoporosis before I had a formal diagnosis, because in my early 50s, I guess, I went to a Wellman clinic, and one of the things they do there is a heel scan. And the result was that they said, you know, slightly lower than we would expect. You might be a little bit at risk of having a lowish bone density. And I did nothing about it, of course. You know, it was just one of those things, and it sort of got forgotten. But then a few years after that, I had 2 teenage daughters, and I was trying to encourage them into good diets and all that sort of thing. And I thought maybe I should go back and get that checked out. Now, because I hadn't broken a bone at that point, there was no treatment available to me at that time. We're talking 15 years ago now.
Oh.
So I paid for my own DEXA scan, which showed that I was osteoporotic, but still kind of shrug and didn't really think too much about it. And then I had a pratfall on the pavement, just literally running, tripped, bang. And I had a lot of trouble with my chest in the few months after that. And it took a while for the rheumatology people to realize that I'd actually fractured 3 ribs, and that was part of what was causing the problems. And I mean, thumbs up to that rheumatology consultant, because he he was the lung consultant. He sent me straight to rheumatology. Said you shouldn't have cracked ribs just from a fall from standing height, no matter how fast you were running at the time. And that was when I got the formal diagnosis. And then I was put on the standard bisphosphonate pills. And so that was about 13, 14 years ago, I guess. So that was how I sort of came to it, if you like. That was how I got my diagnosis.
Okay. And we often hear from men who tell us that sometimes they might come across quite a lack of awareness of osteoporosis in men. Is that something you've sort of experienced on your journey?
Absolutely, it is. People express surprise if for whatever reason I don't use a foghorn to talk about it, but if it comes up, oh, you've got osteoporosis, and there is still that sense of, I thought that was something that women got, old women got. I think that was a very strong sense that I had 12 years ago when I started in on this journey, and I think it's not quite as bad now. I think there's a bit more awareness now that actually men get it, and also there's some awareness that actually younger women and even occasionally younger men can get it. But definitely it was the sort of knee-jerk reaction was, oh, it's older women, postmenopausal women, and that's definitely still an education issue. But I think it's complicated by the fact perhaps that men don't talk about it very much, if at all. I think there's less word of mouth about it, I suppose, about men and between men.
Yeah, I think you're absolutely right. You mentioned that, this lack of awareness, certainly from working on the helpline at the charity, we don't hear from anything like as many men as we do from women, of course. But when we do, there's often a mention of a feeling of isolation. They don't really see or hear about men in sort of settings where they're being treated. I mean, you've mentioned reaching out for support. I'm guessing that you found that was really quite a helpful thing for you to do. And do you think that's helped with that sort of sense of isolation and would help others?
Absolutely. I mean, it certainly helped me immensely. Once I sort of got to grips with the fact that I did have osteoporosis, and I kind of leaned on the hospital to do various tests to make sure that there wasn't some other cause, some other factor behind it. But no, it was what they call idiopathic. In other words, we don't really know why. My approach to something like that is not to hide from it, but rather to go and learn about it and sort of get my arms around it, if you like, and understand it. So obviously, I found the osteoporosis charity. It was called the National Osteoporosis Society back then, and joined and read all the documents and called the helpline, and that was just immensely helpful. Because you then realise that you're not on your own, and there's a huge amount of authoritative advice and guidance, and it's easy to understand, and it's become even better over the years, I know. So that was immensely helpful to me, and when I decided to volunteer, I kind of made myself known to the society and said, well, I've got this skill set and this experience, and oh, right, would you like to come and do this or come and do that? So I quite quickly got involved, and again, I found that really helpful because then you're part of the community. Even just joining a local support group, it becomes part of the community, and then you just feel supported, and you feel, as I said, that you're not on your own, which is a really important thing.
Absolutely. Yeah, definitely. And do you find socially, you mentioned support groups. I know obviously with the whole impact of the pandemic, a lot of that sort of face-to-face support went online and disappeared for some time. But do you find that you're able to meet any other men who are affected with osteoporosis as well?
I only ever met one other man in these support groups. again, the prevalence of men is lower, but it's not, dramatically lower. It's lower than women. But also, I just think men don't do that. They
Yes.
don't join. They don't go to social events for all sorts of reasons. Not just because they're shared or in denial or whatever, but they just may be busy and it just isn't their thing. So I do think it's important for us to try and find other ways to reach the men, because I think they do need information and advice, because that's what makes you feel better about it, rather than living in fear or living in denial, in which case you're then going to go out and break bones, and that then has knock-on effects, which can be quite serious.
Absolutely, yeah, and being able to make informed decision and choices about what you do with your condition and how it's managed, very important. You're absolutely right. Can I ask a little bit about your experience of fractures, living with fractures as a man, how that's been for you? Has it affected what you do, or what you may or may not have done in the past, and how you do things differently now? Has that changed anything for you?
It's made me a little bit more careful. I've had 2 episodes of broken ribs and one shattered shoulder blade. The shoulder blade is a bit more unusual, and I can't. You can't measure the bone density in my shoulder blade, or at least it hasn't been measured. So I don't know, whether I actually put that. But it was a fall from standing height. So one proposes that it was osteoporotic. So yes, those experiences, which were transitory. That takes sort of 6 weeks to get better, and then you're fine. There's no. Well, I probably have slight movement issues in my shoulder, but no lasting effects really. But it does make you a bit more careful, because you don't want to do that again. You don't want to do something a bit more serious, like breaking a leg or breaking a hip. It hasn't constrained my lifestyle hugely, though. I'm just a bit more thoughtful about moving, about jumping, about putting myself in a situation where I might fall. I try not to be burdened by it. That I don't want to be a victim of it. I just wanted to know that I just should be a little bit careful about certain aspects of my life, and just think about what I'm doing. But I still go to the gym and do all sorts of sports, because I think it's really important to keep my system going, if you like. And in particular, I'm 71 now, and so if I don't do something, my sort of muscle quality is going to fade, and I think it's important to maintain that, to support the skeleton. So I'm doing that, and I know there was, in a few years ago, there was a flurry of worries about exercise and certain positions and so on, that that you could particularly put the spine at stress. But I think that's been sort of mitigated now, that actually, as long as you don't do anything sort of jerky or extreme, you can still do all the exercises that you'd want to do. So yeah, so it's made me more careful, and it's also made me do more regular exercise. So that can't be a bad thing, can it?
Good. That's the best combination, isn't it? Absolutely.
Yeah.
Yes. So, in summary, is there anything that you would want to say to other men that are living with osteoporosis, either with or without fractures? Is there any key messages that you would like to share?
Yeah. I ignored it for quite a few years, and yeah, maybe as a result of that, I made it worse. Because I've now been on treatment for 12 years, and that continues, and my bones are relatively stable with the treatment, which is better than it just falling off, as it would have done if I'd done nothing at all. But I probably should have actually tackled it earlier. I should have got involved earlier and thought about it and understood it. I think fear comes from ignorance, and I think it's better to know about this stuff. I know it's not for everybody, but I personally am very happy with the sort of patient as partner approach. So I like to understand as much as I can about the subject, and that makes me feel better. And I think that will be true for a lot of people. So really, I just think, men should realize that, they're only 2 or 3 times less likely than a woman to fracture. It's not like they're 50 or 100 times less likely. So it's out there a lot, and I just think we don't see it. And I think that men need to be able to go to their GP or their practice and be able to ask the right questions. So, education is and getting a hold of it, I feel is really important.
Absolutely. Yeah, terribly important. That's really, really useful messages. Thank you so much. It's been wonderful to hear about your experience. Thank you ever so much for sharing it with us. And you've also very nicely mentioned some of the services that the charity provides. And of course, for anyone listening to this, there will be signposting to that as part of this video content for Bone Matters. So thank you very much for sharing your story with us today, Nick. That's been lovely.
You're very welcome, Kirsty. Nice to talk to you.